What you may not know is that progesterone is made after ovulation in every cycle, and it's actually what controls your period coming, and it's essential for implantation. The window when an embryo can actually implant in your uterus is very narrow, and that window opens and closes with progesterone. Recently, I had a patient come and see me, and she was having pretty regular periods, but wasn't getting pregnant. And on her blood work, it showed that she had low progesterone and high estrogen. She was told that low progesterone was her problem, that she had estrogen dominance. This was preventing her from getting pregnant, and she was put on this progesterone every single day. This constant progesterone exposure prevents the lining from being able to accept an implantation. Both too little progesterone and too much progesterone make it so that you're unable to get pregnant, even if there is an embryo en route that theory could implant. Welcome back to the As a Woman podcast. I'm Dr. Natalie Crawford, and today we're talking about a hormone that doesn't get nearly enough attention, and that's progesterone. You may have heard a lot about estrogen, but progesterone is just as essential, especially when it comes to supporting ovulation, regulating your cycle, and it is essential for pregnancy. In this episode, we are diving into what progesterone actually does in your body, the most common signs and symptoms of low progesterone, and what you can do, both naturally and medically, to support healthy levels if you're trying to conceive or if you are having miscarriages. If you're struggling with irregular cycles, spotting, mood changes, or fertility challenges, this episode will help you understand your body better, feel empowered to ask the right questions, and take the next steps with confidence. So let's dive in. I get asked questions about progesterone every single day in clinic and probably every single day in the DMs on social media. That is because there are so many misconceptions about it and a lot of even well-meaning providers who may be doing the absolute wrong thing when it comes to your progesterone. So in this episode, we're going to dive into what it is, and I'm going to tell you a story about one of my patients and give you a lot of tools so that you can be a better advocate for your health. Progesterone is the progestational hormone, named very aptly because it is the hormone that your body makes in really high levels when you get pregnant. What you may not know is that progesterone is made after ovulation in every cycle, and it's actually what controls your period coming, and it's essential for implantation. In fact, the implantation window, the window when an embryo can actually implant in your uterus, is very narrow, and that window opens and closes with progesterone, meaning both too little progesterone and too much progesterone make it so that you're unable to get pregnant, even if there is an embryo en route that theory could implant. This is how some progesterone-only birth controls work. Things like the Mirena IUD or the progesterone mini pill. This constant progesterone exposure prevents the lining from being able to accept an implantation. So it directly modifies with the implantation window. Some of these contraception methods work in other ways as well, but just to have you understand how important progesterone is and how impactful too much or too little can be for your body when it comes to getting pregnant. So when we think about a normal cycle, there is a lot of myths and misconceptions about progesterone. I want to break it down for you right here. Every month you have a group of eggs that are available. Each egg grows inside a follicle. The brain sends out FSH, or follicle stimulating hormone, gets an egg to grow, and it makes estrogen. This is the follicular phase. This is an estrogen dominant phase. That's normal. And there's no progesterone in the follicular phase. In fact, once you have that mature egg, then your body will interpret this very high estrogen level and send out a surge of LH, or luteinizing hormone. LH first allows the follicle to rupture, the egg to be released, and then the follicle will reform. Well, that follicle becomes an important cyst called the corpus luteum. And the corpus luteum is truly what your body needs to both get pregnant and to stay pregnant in early pregnancies. This is because the corpus luteum makes progesterone, and it makes progesterone at pulses from the brain. So unlike what you may see in a graph where they mark the average progesterone, which will have a nice little raising line in the luteal phase, progesterone is in pulses, up and down throughout the entire luteal phase. In fact, we say progesterone can be anywhere from 3 to 40 nanograms, and that's totally normal anywhere in the luteal phase. Anybody who tells you that your progesterone should be a set number to be consistent with a good luteal phase is actually not telling you the truth, and they're misinterpreting what's actually happening physiologically. And that's important for you to know because somebody may tell you this. It's also important to know that if you have low progesterone or you're diagnosed with estrogen dominance, that may not be a real diagnosis. I'm going to go through later in the episode when that's important and what you should know and how you advocate for yourself. But typically, the corpus luteum makes progesterone in pulses for the whole luteal phase, and that corpus luteum tends to last about 12 to 14 days. If you get pregnant, fun fact, the pregnancy comes in implants and it makes a hormone called HCG. That's the hormone you'll test on a pregnancy test. HCG actually binds to the same receptors that LH does. I know that sounds complicated, but the net result is that HCG from the pregnancy causes your body to continue to make progesterone. We actually in the medical world say that it rescues the corpus luteum. Your body doesn't naturally make progesterone from the pregnancy itself until the placenta is fully grown in around 9 to 10 weeks of pregnancy. All of that time up before then, it is reliant on progesterone production from the corpus luteum, which is stimulated by the brain and LH pulses after ovulation. And then once a pregnancy is in place, it's actually stimulated directly from the pregnancy itself. That's why progesterone can be important in determining the strength of a pregnancy. So checking progesterone levels in a pregnancy, different and predictive versus checking progesterone levels in a luteal phase, which by definition fluctuate depending on when you checked them in relation to an LH pulse, which you often do not know. Inside your body, progesterone stabilizes the endometrial lining. We compacts it down and prepares it for that implantation. It also changes your metabolism so that you're ready for that implantation to occur and all of your energy can be directed to a potential pregnancy. Again, progestational, it's the pro-pregnancy hormone. So you might notice feeling more bloated, tired, sleepy. Your body might be hungrier. It's trying to slow down. And that is all normal and aligned with trying to help you get pregnant. If progesterone fluctuates, can you have low progesterone or can you have too much? Having too much progesterone is not really a problem at all. And in fact, when you're pregnant, your body naturally makes tons of progesterone. But having too low of a progesterone can sometimes be a problem. In my opinion, I always say this is reflective of an ovulation disorder most of the time because the corpus luteum, which makes progesterone, comes from the follicle that grew and matured the egg. So if you're not growing a good follicle or you're having some ovulation disorder, you might not have a great corpus luteum or make progesterone well either. We also see symptoms when your progesterone can be low. So you may notice a short luteal phase, spotting in the luteal phase. You might notice that overall you feel more mood changes or PMS-like symptoms. You may be more bloated or have some of those PMS symptoms, but you also may have more infertility, difficulty getting pregnant, or potentially miscarriages. And we're always talking about progesterone when it comes to fertility and when it comes to fertility treatments as well. Recently, I had a patient come and see me, and she was having pretty regular periods, but wasn't getting pregnant. And she ultimately maybe tended a little more holistically, a little skeptical of doctors. So she went to go see a holistic hormone specialist here in town. She had a ton of blood work drawn. And on her blood work, it showed that she had low progesterone and high estrogen. And she was diagnosed with both estrogen dominance and low progesterone. And she was put on a compounded hormone that provider actually sold to her that included both progesterone in it and actually had testosterone as well. But so she was told that low progesterone was her problem, that she had estrogen dominance. This was preventing her from getting pregnant. And she was put on this progesterone every single day. And do you know what? You already learned that progesterone opens and closes the implantation window. Daily progesterone is birth control. She was trying to get pregnant, had been trying for almost a year, and was put on birth control by a hormone specialist when she went to seek help. That prevented her from getting pregnant for the next 6 months. And she was devastated when we discovered this. And she's not the only one. Probably once a week, I see some story of this. I even had a patient who was put on differing doses of progesterone, less in the follicular phase and more in the luteal phase. And there's so much nuance about progesterone being important that these are women who were trying to do the right thing and help themselves get pregnant and have healthy hormones. And instead, they were prescribed and they took birth control. It just wasn't packaged called birth control. It was called progesterone to help your hormones and help you get pregnant. That's why understanding this information is so crucial. The patient I'm talking about was able to come off the progesterone. We did a full fertility evaluation, and we were able to help her get pregnant with some ovulation induction medication. So at the end of the day, she was able to get pregnant and had a happy ending, but it was a very frustrating moment for her. And this is just highlighting the fact that even a lot of providers don't truly understand progesterone. And so if you are considering supplementing with progesterone or somebody diagnoses you with estrogen dominance, really stop for a minute and think twice. In this patient, her labs were checked in the follicular phase, meaning she actually was naturally estrogen dominant. She was growing an egg, which made estrogen, and naturally progesterone low because she had not ovulated yet. So she was diagnosed with something which was completely false and made up because the person who drew the blood didn't truly understand the menstrual cycle and what hormone changes are normal or abnormal. A lot of different things can actually cause low progesterone. So if we think about the spectrum of ovulation dysfunction, we know that you can have abnormal progesterone when you have prolactin abnormalities, thyroid abnormalities, hypothalamic dysfunction, and even PCOS patients. So a lot of these same hormone issues that might cause cycle abnormalities can also present with low progesterone. And what I want you to take away is that's all tied back to poor ovulation. The follicle, which grows the egg, is the substrate, the base of what's going to make progesterone. And in order to make that progesterone, the ovary has to be able to interpret those signs from the brain. So if there's brain-ovary miscommunication, you're also not going to get progesterone produced. Checking a progesterone level, you'll hear me talk about this at length because somebody will come in and say, I want to get a progesterone level checked. I'm worried my progesterone is low. Is progesterone my problem? And it might be, but that doesn't mean that just checking a random blood test is going to be helpful. So let's talk about when it is and when it's not. Very often you'll hear us talk about a day 21 progesterone. Well, this really should be called a mid-luteal progesterone. About 1 week after ovulation, you can check a progesterone blood test, and the point is to confirm if you did in fact ovulate. Any level over 3 nanograms is consistent with ovulation. In fact, if you check a day 21 progesterone the wrong time, it might give you the wrong information and you might have the exact wrong treatment done. A good example is somebody who might have a 35-day cycle is probably ovulating around day 21. They're not going to have an elevated progesterone. But it doesn't mean that they're not ovulating. They just are ovulating on a different time frame. So even though it will be called day 21, it should not always be checked day 21. It should be checked about 7 days after when you think somebody ovulates, or the other way to look at that is 7 days before they expect their next period to come. That progesterone level, again, is only important in confirming, did you ovulate or did you not? People have tried to look at, does a progesterone level of 10 support a good luteal phase or not? And I'm telling you, that's not physiologically how the ovaries work. And so your progesterone easily could be above or below 10. And in the context of it being a good luteal phase, that's not helpful information. That doesn't mean that the luteal phase isn't important or that abnormalities are not real, because they are. Both of those are true. But the best signs of an abnormal luteal phase actually comes from cycle tracking. So if your luteal phase is short, or if you are having spotting in the luteal phase, those are the clinical signs that your progesterone is low and it's not supporting an appropriate luteal phase length. The other thing that we see is that if your progesterone is low, we get worried that it could have an association with miscarriage. Now, this is a complex topic because is it the chicken or the egg? Meaning the corpus luteum makes progesterone. However, a pregnancy makes HCG, which, as we already talked about, stimulates more progesterone production. Even though your progesterone is going to fluctuate throughout the luteal phase, the moment you get pregnant, you now have a constant and increasing exposure to get more progesterone made. HCG doubles approximately every 2 days. So if you get pregnant, your HCG is going to go from 100 to 200 to 400 to 800. This is a constant and increasing stimulus telling that corpus luteum, make progesterone, make progesterone. So your progesterone levels might be checked with a pregnancy, especially if you're having vaginal bleeding with a pregnancy, to try to determine if things are looking normal or not. And in that case, we see that progesterone levels over 20 are highly suggestive that things are good. Progesterone levels of less than 5 are highly suggestive that things are not great. And in between is the gray zone. Well, this is because an abnormal pregnancy is often not going to have the ability to make a good progesterone. It's not making enough HCG, therefore not stimulating enough progesterone. If you've ever gone through fertility treatments, you know this because people might check your HCG every 2 days to see if it's doubling. Abnormal pregnancies double at a certain pace. And so if yours is not raising at a set pace, it's not stimulating enough progesterone production. And this is how the human body is wired so that an abnormal pregnancy doesn't progress too far and in fact helps your body miscarry. So even though a low progesterone might be very normal in context of an abnormal pregnancy, can low progesterone contribute to miscarriage? And this has been a question that's been looked at and is kind of hard to answer, to be honest. So a lot of this, the too long version is, I think it depends on when progesterone is started and how we help people the most. So if you have recurrent pregnancy loss, there were 2 big studies done looking at starting progesterone once you had a positive pregnancy test. In one study, the women who started progesterone had vaginal bleeding, so they were at risk of having a pregnancy loss again. And in the other group, there was no vaginal bleeding. In the study where people had vaginal bleeding and they'd had history of recurrent pregnancy loss, so at least 2 prior losses, adding on additional progesterone improved their odds of staying pregnant. However, in the group without vaginal bleeding, there wasn't a difference. This led a lot of people to say progesterone is not helpful in the recurrent pregnancy loss population unless you concurrently have vaginal bleeding. However, there was also a study done, and this was a smaller study, but this looked at women who had progesterone started in the luteal phase. And if we truly think progesterone's impacting the pregnancy, starting it once you're pregnant might be too late. This was where progesterone was started 3 days after a confirmed ovulation in the luteal phase in women with 2 or more prior losses without any history of vaginal bleeding. To be honest, there were some other more strict inclusion criteria, but this study did show a significant difference in people who got pregnant and stayed pregnant when the progesterone was started after ovulation versus women who didn't have any. And this is my approach a lot, meaning progesterone is probably helpful in the context of recurrent pregnancy loss, but it is going to be most impactful if we are starting it after ovulation. Again, big red warning flag, as I see a lot of people say, here's a progesterone prescription, just start taking it cycle day 14. Well, what if that's not 3 days after ovulation for you? Another win for tracking your cycles, knowing when you ovulate, and starting progesterone appropriately. For the record, the study had different doses, either 100 to 200 milligrams. This was vaginal progesterone, and it was used twice a day. So you'll often see some version of that, but there's not one single right way that is done. This is why a lot of fertility doctors will also use progesterone in addition with other treatments. So if I have somebody who's not ovulating well, I often will do Clomid, try to get a better substrate, a better follicle, but you'll see me add progesterone on in the luteal phase as well. When you're doing fertility treatments, some clinics may not add progesterone on. And in fact, if I'm getting you to ovulate a better follicle, I should have a better corpus luteum. So that's not the wrong answer, but it's very important for you, the patient, if you are having abnormal luteal phase symptoms, like a short luteal phase or that spotting, those are the clinical signs that something's wrong in your luteal phase. In addition to testing to see why, do you have any of those hormone issues causing irregular cycles? If the ovulation induction medications are not fixing the problem, you might want to consider luteal progesterone, but it needs to be timed after ovulation. I don't love starting progesterone with a pregnancy or when it comes to starting progesterone every single day, obviously is the wrong answer. I'll say here's a caveat. If you don't have a history of recurrent pregnancy loss, oftentimes you wouldn't fall into the category to start luteal progesterone. Many of us will do it if you have ovulation dysfunction and you're getting treatment anyway, because it's something with very low risk and potential benefit when done in the right hands. When it's done outside the setting of somebody who knows when to start it, it can be terrible, like it was for my patient whose hormone specialist prescribed her daily progesterone. The other thing is if you are pregnant and you have vaginal bleeding, you go into your doctor, they may start you on progesterone at that moment, and that's not wrong either. It's something to ask about and to understand why you may or may not be prescribed it. But again, when you start it, likely is really important. All right, so what should you do about progesterone if you're concerned your progesterone is low, if you're having trouble getting pregnant, or you're having pregnancy loss? Number one, track your cycles. Tracking your cycles, knowing when you ovulate, knowing what is really happening in your luteal phase is going to be the key. So pick whatever tracking method works the best for you. Number two, I want you to know that checking a luteal progesterone has limited utility. Again, we should be checking it about a week after ovulation, and it is only confirming did ovulation occur or did it not. Treatment should not be administered or withheld because of whatever that value may be. If you clinically have signs of a luteal phase issue, then treatment is indicated regardless of if your progesterone is randomly high at that moment. If you are noticing those clinical luteal phase issues, we should bring that up in a look for ovulation disorders, including prolactin, thyroid, and some basic hormone testing like FSH, estrogen, and an AMH level. If your doctor doesn't suggest these, ask. Also, we can sometimes see luteal phase spotting specifically with endometrial polyps. So there might be a utility to doing some anatomic evaluation to make sure the spotting isn't due to an anatomical cause and that it is truly hormonal. My treatment, if somebody does have a luteal phase issue, number one, I like to make sure we know everything. So again, all the testing. But assuming this does look like an ovulatory cause of a luteal phase defect, if it's thyroid or prolactin, we want to treat those specifically. Most of the time, it's actually falling into what I call hypothalamic dysfunction. So the brain's just not sending out quite a strong enough signal. And this is a case where I love to help the brain out, send out a stronger signal. And I find that Clomid can be a great choice here. Clomid is a medication called a SERM, a selective estrogen receptor modulator. Big fancy word, but essentially binds to estrogen receptors in the body. But at the brain level, the brain then thinks your estrogen is super low, and it's going to send out a stronger surge of FSH. More FSH grows a better follicle. A better follicle is going to be a better base to make more progesterone. And in fact, Clomid alone can help a luteal phase defect. I often will combine Clomid with monitoring, meaning an ultrasound to see when you're ovulating, and then starting progesterone 3 days after ovulation in the luteal phase just for additional support. It's not wrong to take progesterone alone, but again, you want to start it after ovulation, and we want to make sure we know why you have a luteal phase defect. Sometimes people might shortcut it and not look for answers. So there could be something very easy to treat, like a thyroid abnormality. So why is it low? Get the diagnostic testing. Progesterone alone is not wrong, but I like to use it best with really getting to the root cause of the problem, which is an ovulation disorder. Now, if you're having recurrent pregnancy loss, looking for some of these hormonal issues I think is essential in addition to other causes of pregnancy loss. And this might be genetic or autoimmune or anatomic. If we find that everything's pretty normal except coming down to maybe these hormonal issues or a luteal phase issue, I'm an advocate if your doctor wants to start you on progesterone, ask if you can start it after ovulation instead of waiting till you have a positive pregnancy test. This is going to require that you have regular cycles, you know when ovulation is, but the data supports that is going to be the most advantageous pathway. So that's something you might have to advocate for yourself. And then what about naturally? Are there things that we can do to help our progesterone production naturally? When it comes to your diet, it's really important to know that yes, harmful things, ultra-processed foods can be bad. Your fruits and vegetables, which are antioxidants and have fiber, are good. But actually, cholesterol is really important in hormone production. And cholesterol comes from those healthy fats. So healthy fats are the backbone for hormone production. So make sure that you're not on a low-fat diet or you're not restricting your calories. Make sure that you are getting enough sleep because that's when your body heals itself. And there are certain vitamins and nutrients which actually can help the production of progesterone even more. So some of these include vitamin B6, magnesium, zinc, and in fact, melatonin. Melatonin is one of the ones that I love to recommend. You have to be really careful with melatonin. It's both an antioxidant, but it also works at the brain level, and it can be associated with improvement of a luteal phase defect, but only at appropriate doses. You should only take between 1 to 3 milligrams of melatonin a night and not more. You can actually find melatonin 10 times this amount easily over the counter. Some of my patients even take a children's version of melatonin in order to not take too much. That is one of those vitamins where too much can absolutely be harmful and shut down some of your brain's response. So you have to know that you're taking the right amount. But these are things that I can recommend to somebody sometimes to make sure that they are taking the right thing. And the other vitamin that I like is vitamin E. Now, of course, a great thing to do to get vitamin E is from a lot of your fruits that are really good antioxidants. Things like blueberries can provide some natural vitamin E for you, and that can also help out with the lining. So if you are struggling from pregnancy loss, from fertility challenges, or you think that your cycle might be abnormal, I really recommend that you track your cycle so that you know your body the best. Advocate for testing if you have a luteal phase that's abnormal, but know that testing is not just a mid-luteal progesterone level. That's only telling you, did you ovulate or not, which probably in this case, you think you are ovulating, and you are, just there's some dysfunction within that process. Appropriate testing is actually much more comprehensive, looking at a bigger panel of hormones and looking anatomically. Treatment should include consideration for luteal progesterone, consideration for ovulation induction, and of course, treating the underlying cause. Progesterone opens and closes that implantation window. So when you start it is just as important as if you take it. And know that both too little and too much can be problematic. Hope this episode helped you learn a little bit more about your body. A little promo for my book, The Fertility Formula, which is going over all of these basic facts, how you advocate for yourself, questions to ask, and understanding what is normal so that you can understand when things are off, what you need to do about it. You can learn more about the book at nataliecrawfordmd.com/book. Thank you so much for being here today. Hope you learned a little bit more about your body. Thanks, friends. Thank you for listening to the As a Woman podcast. If you're ready to take control of your reproductive health, my new book, The Fertility Formula, is your next step. It's a science-backed guide to understanding your hormones, optimizing your fertility, and owning your reproductive future. You can order your copy and learn more at nataliecrawfordmd.com/book. And as always, follow along at Natalie Crawford MD for even more support. Because knowledge is power, and your health deserves a formula made just for you as a woman.